Assalamu alaikum. Dear listeners, I am Yakubbekova Soxiba, the Department of Oncology. Today we should discuss theme sarcomas of soft tissue. Definition: sarcomas are malignant tumors that arise from skeletal and extraskeletal connective tissues, including adipose tissue, bone, cartilage, smooth muscle, skeletal muscle. Statistic of soft tissue sarcomas, rare and unusual cancer. About 1% of adults human cancers, 15% of pediatric malignancies, and most commonly occur and extremities, 15%, and other sites, abdominal cavity, retroperitoneum, trunk, thoracic region, and head and neck. Histological types of soft tissue sarcomas, cell of origin, adipocyte, sarcomas type, liposarcoma. Fibrohistiocyte sarcomas type, malignant fibrous histiocytoma. Cell of origin, fibroblast, fibrosarcoma, smooth muscle, leiomyosarcoma, skeletal muscle, rhabdomyosarcoma, vascular angiosarcoma, Kaposi's synovial sarcoma, melanocyte, malignant melanoma, and unknown cell of origin, Ewing sarcoma, and epithelioid sarcoma. Histological is determined by anatomic site. Extremity, malignant fibrous histiocytoma, liposarcoma, and retroperitoneal liposarcoma and leiomyosarcoma. In this picture, we can see Kaposi's sarcoma. Sarcoma's age is factor in histology. This is childhood embryonal rhabdomyosarcoma, bone, Ewing sarcoma, osteosarcoma, and synovial sarcoma is more likely to be seen in young adults, 5 years old. Liposarcoma are the predominant types in the oldest population. In this picture, we can see microscopic histological types. The biological behavior of sarcomas is extremely variable. Histologic grade is a major prognostic factor based on degree of mitosis, cellularity, presence of necrosis, differentiation, stromal content, low-grade sarcomas, better differentiated, less cellular, tend to resemble the tissue of origin in some extent. Mitotic rate is low, growth lower, low risk of metastasis, a high risk of local recurrence after surgical removal. And if high-grade sarcoma, highly cellular, poorly differentiated mesenchymal cells with marked nuclear abnormality, high mitotic rate, and anaplasia. Grow rapidly, show extensive local invasion, metastasis early through bloodstream. Sarcoma's genetic risk factor. This is neurofibromatosis, von Recklinger's disease, Lee-Fraumeni syndrome, retinoblastoma, and Gardner syndrome. Phosphorylation of retinoblastoma, 50% of sarcomas. Inhibition of p53, 16% of sarcomas. Genetic risk factor of sarcomas consists of radiation exposure, lymphedema, post-surgical, post-irradiation, parasitic infection, trauma, chemical, polyvinyl chloride, hemochromatosis, and arsenic. And the diagnosis of sarcoma consists of physical examination, assessment of the size of the mass and its relation the new vascular and bone structures. Extremity sarcomas usually present as painless mass. Biopsy, any soft tissue mass that is symptomatic of enlarging or any new mass that persists beyond 4 weeks should be sampled. And usually incisional or core biopsy preferred. The incision should be centered over the mass in its most superficial location. Imaging MRI preferred enhances the contrast between tumor and adjacent structures, provides excellent three-dimensional definition of facial plans. Combination of computer tomography and MRI did not significantly improve accuracy. Workup, evaluation for sites of potential metastasis occur in less than 3% of adult sarcomas. For extremity lesions, lungs is the principal site for mets. For visceral lesions, the liver is the principal site. Low grade, the risk for mets 15%, and higher grade, the risk for mets 15%. Extremity sarcomas, MRI of the lesion, computer tomography, chest, bone scan, visceral sarcomas, MRI if needed, get the chest and abdomen, childhood sarcomas, PET, MRI, and bone scan if they needed. In staging sarcomas, soft tissue sarcomas, histopathological grade classification GX, G1, G2, G3, and 4. Grade cannot be assessed, well differentiated, moderately differentiated, purely differentiated, and undifferentiated. Primary tumor TX, T0, T1, T2. Primary tumor cannot be assessed. T0, no events of primary tumor. T1, tumors 5 centimeters or less in greatest dimension. Superficial tumors, deep tumor, tumor more than 5 centimeters in greatest dimensions. T2, deep tumor. And in one stage, A, low grade, small, superficial, and deep. Stage 1B, low grade, large, superficial. Stage 2A, low grade, large, deep. Stage 2B, high grade, small, superficial, deep. Stage 3, high grade, large, deep. Stage 4, any metastasis, if you have any metastasis. Sarcoma treatment, surgical excision. The only hope of cure, the goal is complete removal of the tumor with negative margins and maximal preservation of function. Lung sparing procedure should be performed when possible. Less radical procedure or do not adversely affect local control of outcome. Treatment, the best excision with 2-3 centimeters margins. The centrifugal growth created pseudocapsule. Malignant cells penetrate this capsule. 90% recur with only removal of visible tumor. 13% recur after excision of tumor bed without radiotherapy. Radiotherapy sarcomas, soft tissue sarcomas, external, beam therapy, and standardized files. Brachytherapy, seeds of iridium, radiotherapy, indications, high grade of the limbs, intermediate grade of the limbs with close or positive margins. Little role in low grade should be considered for a recurrence. And for survival, limb conserving plus adjunct radiotherapy and amputation. Preoperative, 15 gray dose, Post-operative 16 and 17 grade dose. Pre and post chemotherapy double the one complication, slightly better functional outcome. Sarcoma of tissue chemotherapy adjuvant and no adjuvant. Adjuvant chemotherapy controversial meta-analysis improved 15%, but not overall survival. Doxorubicin base in child hold around cell tumors. Initial chemo improved survival from 10% to 16%. Necrosis of 90% confers better outcome. High dose chemo with salvage autologous for recurrence. Recurrent disease, local extremity, if isolated, should undergo resection and radiotherapy if feasible to free long-term survival. Resection of pulmonary metastatic condition, primary tumor controlled, no extrathoracic disease, and complete resection of all lung disease appear possible. 13% 3-year survival after complete resection. Chemotherapy for metastatic disease. Palliative, not curative therapy for unresectable pulmonary mets, extrapulmonary mets in more than one site. Poor prognosis, median survival less than 1 year. Chemotherapy for metastatic disease. Sarcoma tissue adrimicin, ifosfamide, dacarbazine as single or combination, 20-40% response rate. Leiomyosarcoma, doxatel with gemcitabine. Angiosarcoma, paclitaxel with doxel. New chemotherapy, trabectedin, product from marine tunicate, stenocidotubinat. These facts, 10 and 20 cases per million, similar incidence in males and females, only 0.2% of all tumors origin. Stomach, 70%, small intestine, 20-40%, colon and rectum, 5 and 13%, esophagus, 5%. Clinical presentation, abdominal pain, bleeding, mass obstruction, primary tumor only 46%, metastatic disease 47%. Prognostic factors, no uniform prognostic guidelines per PX associated with increasing tumor size, metastatic disease, or presentation high grade, primary treatment only surgery. Different diagnoses of GIST, leiomyoma, schwannoma, lipoma, angiosarcoma, sarcomatoid carcinoma, solitary fibrous tumor, abdominal fibromatosis, endometrial stromal sarcoma, and other. Important different diagnoses of GIST with possible reception expression. Modified risk statistic post-operative recurrence. From molecular biology to novel therapies, ligand receptor activate of signaling pathways and proliferation and cervical. Imatinib missile mechanism of action. Imatinib misaligned occludes the ATP binding pocket of the KIT kinase domain. This prevents substrate phosphorylation and signaling inhibit proliferation and survival. Imatinib misaligned in metastatic. Pediatric sarcomas, sarcoma, rhabdomyosarcoma, and osteosarcoma. Osteogenic sarcoma, the most common bone tumor, peak incidence, second decade of life, females earlier than males, maybe primary or secondary, and most commonly located in metaphysis of lung bones, especially around the knee. Treatment of osteogenic sarcoma: chemotherapy, surgery, sexual selected lung meds, and chemotherapy. Ewing sarcoma, the second most common bone tumor, the most common location, diaphysis of lung bone, frequently bones of pelvis. The most common sites of mets, lungs and bones, maybe in bone marrow. Ewing sarcoma molecular biology methods of diagnosis, T and T in approximately 95% of cases, prognosis of PTs with PSR positive in peripheral blood and or bone marrow approaches that of PTs with overt metastatic disease. Treatment, biopsy and definite diagnosis, neoadjuvant chemotherapy, surgery plus radiotherapy, and continuation of chemotherapy. Thank you for attention.